started. Thank you so much. Gracias a todos por estar aquí. Buenos días. Today we have the pleasure and the privilege of having, as you see on the screen, Dr. Jadranka Stojanovska from New York. She's an associate professor of radiology and the director of the MRI program in Nalangon, New York University Medical Center. She has an extremely very interesting CV. She was born originally in Macedonia, and that's where she went to medical school. But because of her interest in imaging and radiology, she moved to the University of Michigan, and at the University of Michigan, she built a very successful career. She trained in radiology initially in Macedonia, but then she repeated her residency at the University of Michigan, one of the top-notch and premier medical centers in the US, and this was followed by a molecular imaging fellowship and by a cardiothoracic imaging fellowship. Jadranka has more than 70 PubMed Index publications. She has worked with multiple task forces. She's going to be the chair of the Society of Cardiac MR Committee in 2024. She's also boarded, of course, in radiology and is an active member of the American College of Radiology. And more so than that, she's built an amazing career and extensive research in multiple areas of cardiovascular imaging, including the topic that is, you see on the screen, and is the why, when, and how to perform CMR in patients with devices. At Michigan, as I mentioned, she worked extensively with biomedical engineer at that university, with her cardiology colleagues and radiology colleagues, specifically about this topic and others. And not only that, she's been very active in clinical duties, in research duties, and she also has won awards in terms of the Best Teacher Award at least twice during her tenure at the University of Michigan. And then NYU was lucky to recruit her a year ago, and then she moved from Michigan to New York, where she became, as I mentioned, the director of the Cardiac MR program. Jadranka, thank you so much for being here. We appreciate the time and effort of being away from family and friends in the holiday season, so thank you so much. You're more than welcome, and again, it's a privilege and an honor to have you here. The podium is yours.
Thank you, Hector. Is this working? Okay, it is. Perfect. I'm humbled and honored to be here, and especially when it's in person, because I love to see people and especially how they react, when we're giving a presentation. I do see a lot of trainees, and that really melts my heart, because as Hector mentioned, I've had 2, even more, awards for helping the education of trainees. So not only, I would say, radiology, but also cardiology fellows and medical students. And I'm so honored and so happy to have at least 9, I would say, medical students that I mentor them from their year 1. And most of them are now attendings in radiology, and only one went to dermatology. He was supposed to go in cardiology, but then his mom was dermatologist, and he apologized so many times. And actually, the research that I've done in CID patients was with him, and his father was a cardiologist. He was the dean at the medical school at Michigan. It was really funny when he decided to go into derm, completely different. But as I said, today I'm going to be talking about why, when, and how to perform cardiac MRI in patients with cardiovascular implantable electronic devices. And before I continue, even though I have nothing to disclose, which probably is good for any presentation, but not probably so good for me. It's good to have some, external funding. But most of my funding was coming through NIH, so that was, good, because you can do some other research, I would say. Before I begin, I would like to meet my audience. So I do see a lot of trainees, but I'm really interested in the attendings and other personnel here too. If you can just tell me, if you're from cardiology, raise your hand. Great. If you're from EP, raise your hand. Wonderful. That's awesome. And then industry, I've been told that we have industry here too. And cardiac surgery. Wonderful. So we have representation from anywhere. And I really like to start with 2 trivia questions. And the reason why I've picked these 2 trivia questions is because they are to some extent related to me. Okay. So the first question is, which city is common? Oh no, let's go back. This is the first one because I love this one. Where's the Mother Teresa Memorial House located at? And this is her memorial house. And you have 4 options, which means Calcutta, India, Skopje, Macedonia, Tirana, Albania, and Detroit, Michigan. What do you guys think? I know I'm not in India because most people will say, hey, she's probably, right, most of her work, she did it in India. But what do you guys think? Number 2, Skopje, Macedonia, great, because I guess maybe I gave a hint, right? So she was born and raised in Skopje, just like myself. I moved to the United States when I was 27. And this actually house, I can see it from my balcony. It's like really close, like from here to there. Downtown Skopje, a pretty cool place, yes. The second one is which city is common between ECMO, lymphoma staging, and Kahn syndrome. And I'm really proud of this. So maybe you guys, I gave you a hint. So we have options, Skopje, Macedonia, again, just to trick you. New York, where I'm currently right now, Ann Arbor, Michigan, and Chicago, Illinois. And this is actually the picture of the hospital that combines all these 3 entities, ECMO, lymphoma staging, and Kahn syndrome. What do you guys think? Ann Arbor, Michigan? 3? Yes, 100%. So it's University of Michigan that combines all 3. So let's start with Kahn syndrome. Jeremy Kahn, he came up, described Kahn syndrome, which you all guys knew, right? Because internal medicine, I guess you would know that. He was an endocrinologist, graduated from University of Michigan, stayed there as a faculty, did his fellowship, stayed as a faculty for a longer period of time. I think maybe his whole lifetime. And so that's number 1. Lymphoma staging was done in Ann Arbor back in 1973. And ECMO was invented by Bob Bartlett, who was my research mentor. The first ECMO was actually placed in 1971 in a patient who was with motor vehicle accident. And he's a great guy, in a great shape, in his late 80s, still working in a research lab. And I was so fortunate to learn many things from him. So I don't have anything from New York because I moved a year and a half ago, but maybe next time. So University of Michigan and Skopje. So the objectives. Really here we're going to talk about the role of cardiac MRI in patients with devices. And what I was asked specifically to cover when cardiac MR is indicated in this patient population, which is to answer the clinical question, right, that most the referring physician will have. And then why, and kind of there is really an interplay between when and why. You know, you can answer basically the same question with both, but I try to distinguish between the two. And when we say why, we really need to understand, you know, it's like patient's outcomes, guide procedures, which in EP population that will be targeting or guide the ablation procedures, and then how we do it, which is mainly the practical approach, how we're going to get there. And I worked a lot with EP, both at Michigan and now at NYU. Both are great programs. I truly enjoyed working with all of them. So let's tackle first the question why. So the highlight of cardiac MRI, it's really the use of LGE and its binary endpoint being positive versus negative, which has the ability to decipher the underlying myocardial disease, followed by secondary endpoints, which we're getting from CINEs, and that will be the ventricular volume, the ejection fraction, mass, force. And then next will be like T2 star if we're looking for iron deposition. In that case, this will be the primary endpoint. And then the exploratory endpoints, mapping T1 and T2 mapping. We're using them, but they're still, you know, in a gray zone, I would say. We don't really know what they truly mean unless the numbers are very high. So I'm going to start here with sudden cardiac death, that it's basically seen in the 50% of all cardiovascular deaths, with 25% being their first symptomatic cardiac event. And what we really need to do in this patient population is to identify patients who belong into the, let's see if I can have this, okay, belong into the high-risk subgroups, that will be like up to 15%. And this is the population that is going to get cardiovascular implantable electronic device, right? And that number, if you get all those statistics, that number is really, really high. So currently in the United States, that number is like probably around 12 million for cardiac devices. So I'm not including here the orthopedic devices, so it will be only cardiac devices. Around like 12 million people, and the estimate is that 50 to 75% of this population, this cohort, is going to get device. So this is basically why we need to discuss, most importantly, what I wanted to say, 50 to 75% of this patient population is going to need not cardiac MR only, but MR in general during their lifetime. Whether it's for cardiac or it's for other body parts, they would need to have a MR done. And in the past, the presence of any cardiac device was an absolute contraindication to having cardiac MRI. But now we have learned a lot more with a ton of experiences where we definitely can scan patients with devices very safely. So when it comes to when we can use cardiac MR in this patient population, we really need to distinguish between non-EP patients, right? This usually was developed for EP population, but now the trend goes, we need to have some questions answered in non-EP population. So for example, like I have this patient who had a dilated cardiomyopathy. He had an ICD placed. And in this patient, for example, you can see this is the echo. It's not really moving it was moving before, but nonetheless, you can definitely see here a mass in the LV apex. And sometimes we need to distinguish, is this a tumor or it's a thrombus, right? So that will be one of the indication why we would need to have cardiac MRI done. Another question will be, what is the etiology of dilated cardiomyopathy, which we don't really know. And also we need to make sure that we can identify findings that are going to predict patient's outcome, right? And as I said, these patients will get their ICDs to prevent them from sudden cardiac death. So one of the papers that talks about outcomes in dilated cardiomyopathy, which is related to the extent, location, and pattern of LGE. So here, for example, if we can see free wall, it's not really associated with sudden cardiac death, whereas if the patient has a midwall, and our patient had the midwall LGE, right, that those patients are associated with increased mortality. However, if we do see midwall LGE in the septum and lateral wall, those are the patients that are associated with greatest risk for sudden cardiac death. So that's why cardiac MRI, as I said, especially LGE, is really important in this patient population. This is a patient with HCM who also had an ICD placed, and definitely here you can see a clear-cut HCM with asymmetric septal hypertrophy, LVOT obstruction, SAM, mitral regurgitation, and extensive LGE. So sometimes in this patient, patients, especially at NYU, we follow them up, especially if they belong in the obese category patients, because what we have found that if we put them on a weight reduction, then the myocardial thickness decreases, and they may not even need the ICD down the road. So that is something helpful that can guide patients' management. So this is that the patient had an ICD. When it comes to EP population, cardiac MRI in this patient population is actually pretty established with, I would say, probably about 20 I would say maybe 15 years of experience so far, maybe even more. So the first thing, what is the benefit? Providing information about tissue integrity. And that is really, really important. So this is the first thing what we're going to cover. It's why we actually need to do cardiac MRI, mainly LGEs, to make sure that we can identify areas with central isthmus, which is the critical zone where we need to go, the EP actually folks need to go and then ablate those areas. So the signal intensity within LGE can really distinguish core from infarct periphery, which has the ability to assess the surviving fibers in incomplete scar that it identified as a critical zones. And this is why cardiac MRI is important, to make sure we identify the location, scar location, which can be endocardial, epicardial, intramural location, which will guide further procedural approach. And that really is the key. Even though the endocardial and the epicardial are a little bit more straightforward, the intramural substrates are actually the ones that are not so straightforward. So we'll start with the endocardial origin of VT. So here, I think I can, so here what we can see, we have a transmural LGE in the infraseptal and inferior wall, all the way from the base to the apex. And you see how this scar is actually being extracted and then transported to electroanatomic mapping. And then by low voltages, we will be, or the EP will be able to identify the critical sites. I guess I need to, no, okay. To identify the critical sites where the red is actually scar tissue, the blue represents the endocardium, and then the epicardium is represented by the green color. So this is definitely the targeted zone for ablation in these patients. So epicardial origin, here, these are patients with non-ischemic cardiomyopathy. This was a paper that was published by our group, included 28 patients. And what we basically demonstrated that the ablation sites often confined to the scar tissue. So basically the epicardial, here we have epicardial LGE, which was present in the infralateral wall, and then a little bit going into the inferior wall was extracted. This is the scar area, and the red will be the scar area. This is the green line is the epicardium. And you can see here how the targeted zones are basically evaluated and pinpoint where the ablation can be successfully done. Then moving on to epicardial origin of VT and how the epicardial fat can actually affect ablation procedure. And again, this is also like pretty much most of the cases and publications that I'm showing you is from Michigan group. And here, as you can see, we have extracted the yellow represents fat in the myocardium, in the epicardial side, and then the red, it's basically where the epicardium is. And then this is the epicardial scar area, or LGE. And as you can see here, the critical zones are being identified only in the LGE area, devoid of the epicardial fat. And why this is important? Because when you guys and the EP guys know this, when they basically do their mapping, they can get low voltage, both from the fat and the scar area. So in order to understand that this is not coming from fat and then ablate in a right way, we want to make sure we get rid of the fat. And one of the challenges is the intramural origin of VA, and you can see here that we have an intramural LGE in the basal septum, which is defined here, and I think I have, and there's another one in the lateral wall, and then the septum as well. And here it's really important to identify the intramural LGE, because that can not prevent, but can really present with a very different approach. And what we do here, we also measure the thickness of the scar because of the depth is really, really important. And these are patients with non-ischemic cardiomyopathy. One has a scar tissue at the base and one has at the infralateral area. And this is really important. We also put the coroners and the phrenic nerve to make sure that anatomically they know where it's safe and how they can go after the ablation. Wall thickness by imaging, this is also a cool, let me just go put most of my stuff, okay. So the first image here, it's gonna show you where the isthmus was located at, and this will be the voltage or the electroanatomic map, where definitely you can see where the critical zones are by this dots, and the thickness, and this is all defined by the thickness. So you can see darker the thickness, that means this wall here, which was identified by CT and MR combined, it was like less than 2 millimeter. So that's essentially where the isthmus was. So we have here the thinning of the myocardium, the more like the apical wall, and then we have a little ridge where it was identified, where it identified the isthmus. And how that looked on, should I have that? Okay. So then moving on to improving outcomes, this is also a study that was done in Michigan, where we looked at the association of pre-procedural cardiac MRI with outcomes of ventricular tachycardia ablations in patients with idiopathic dilated cardiomyopathy. 96 patients were included, 41 patients had cardiac MR done, and 55 patients had no MR done whatsoever. So you can see based on this pie chart, which elegantly displays patients with complete success, so that with the green color, you see patients who did not have imaging, their complete success was 24 compared to 63 if the pre-ablation imaging was done. In addition to patients who had failure in ablation procedure were recurrent VT, those were 11 compared to 2%. So now here we see really the value of why we need to do cardiac MRI in this patient population. And here what it shows that patients, here the red line in the Kaplan-Meier curve shows you patients with no imaging, blue with imaging. So, don't know why it's advancing too fast. It just shows us that patients who had no imaging are going to experience VT recurrence, heart transplant, or death at the earlier time point that patients who would get cardiac MRI done before procedure. So another point that highlights importance of cardiac MRI. We also do it for specific mapping procedures, and that will be to see whether there's any LGE in the papillary muscles. So this is a patient who had a scar tissue in the anterior papillary muscle. You can definitely see it here. And that was a good case to target ablation to that particular area. One of the things that it's kind of new entity that it's coming out is patients who have mitral annular disjunction, which basically, if you're looking at here, it's like a fibrous tissue. Oops, doesn't come all the way here, but I pointed out with my arrow. It's the fibrous tissue between where the myocardium ends and the attachment site between the left atrium and the mitral valve. What is important here is to identify whether these patients have a prolapse and mitral valve prolapse. Here, this patient did not, and the recent study that was published in 2020 in JACC, it's actually showed that patients who have mitral annular disjunction with no mitral valve prolapse, they are at higher risk to experience arrhythmias. And this patient, for example, had a very faint Midwall LGE, which sometimes can be seen in this patient population. So this is something new that we really need to probably do a little bit of research but definitely these patients come with PVCs. If the diameter measures more than 8 millimeter, one of the study mentioned that they are associated with NSVT. And we recently had a patient with MAD diameter of 12 millimeter, and they presented it with NSVT. So now will be when, which I said there's a little bit of overlap between why and when, but what I like to touch upon here is when CMR is indicated, which is basically to discuss risk and benefit, right? Because we want to make sure what we do is safe for the patients, and that is the most important thing. Everything what we do is to help the patients. So risk safety profile, I have about 9 papers that I have summarized. Most of them at the beginning they have done, they've used or they have done all the studies on MR conditional, actually non-conditional. They did not include the conditional. Some of them have had conditional, and we have done a ton of patients with conditional MR devices. The only difference is that you want to make sure that you are very cautious and you include all that safety profiling questionnaires in those patients. And definitely we have scanned patients with legacy devices, which are the abandoned leads. So it's not that it presents an absolute contraindication. It just involves more discussion with all stakeholders that are involved. And as you can see here, it's a large patient population across every single paper that I'm going to show you. Some of them are like multi-center trials, some are systemic review and meta-analysis, prospective studies, most of them. There was only one that was a retrospective study, and most of the studies that were even done in Michigan were retrospective and prospective. And you can see here, the sample size is huge among all of those papers. And if we go back and then look at their outcomes, of course that they would include deaths, right? So that would be number one that we're really worried about, right? What if something happens with the patients during the scanner? And as you can see, basically it's very, very safe. Some of the other outcomes were related to the device itself and the leads, because we want to make sure that the leads are functioning properly before, and then we reprogram them. I mean, that will be the EP side, reprogram them after the cardiac MRI was done. And at the beginning, we started in a very safe way, which means we would not keep the patient in the scanner. We would only do LGE. We would inject them with gadolinium before the scan was done, wait 10 minutes outside, then put them in the scanner and only scan them for 15 minutes. So in addition, like the whole, I would say, time consuming to do the scan will be about like half an hour. We wanted to make sure that we will minimize the scan time. That's how we did it before. At NYU, I was really surprised. We do the entire protocol, which takes like up to 1 hour. And the key why we were keeping the patients with 30 minutes or less, it was to make sure that every single protocol or sequence we're going to apply will use very low SAR, which is the specific absorption rate, below 2. However, I have to mention that there were studies that they were done where they compared with low SAR and high SAR, and there was no difference. So, we started in a very cautious way, but then we learned that it's okay. We can actually perform the whole cardiac MR protocol, which means we would include patients who are non-EP, and we're not only be looking at LGE. So, as I said, none of these patients, there's no really a death in any of these patients. And based on our experience at Michigan, I would say from my experience of 10 years, while I was there, we only had one patient who coded on the table, but he was unstable VT patient, and we basically pulled them out immediately, and the patient did fine. In terms of the devices, you would see that it's a very small percentage of devices, whether they're going to function after that or not, but most of it, it's really, really good, and it's safe for the patients. I'll skip through it, and then benefit is, as I mentioned, EP patients versus non-EP patients. When it comes to non-EP patients, as we all know, some patients will get an ICD without even MRI being done. And this is really the key, because most of the time we would like to know what is the etiology of the cardiomyopathy, and this is how we can tailor the whole cardiac MR protocol, because to me, cardiac MR should be really individualized and should be patient-driven based on their symptoms and what are the questions we have to answer. And in this patient population, I'll be very careful. I would not do everything, like do maybe flow, do mapping, only answer clinical question, right? If mapping is the clinical question, yes, we can do it. Is the flow structural heart disease is the question, yes, we can do it. But if it's not, then we really need to make sure that we do a very short protocol with these patients. Or, what is the extent of systolic dysfunction, right? So that's why we can use cardiac MRI. Portions of myocardial and ischemic cardiomyopathy, whether they're viable versus not, and then whether we are, so one of my last patients that I got referral for was a patient with restrictive cardiomyopathy, and it was sent to rule out amyloidosis, which was very critical because the management will be completely different. So when it comes to EP population, as I mentioned, it's providing information about tissue integrity, improving outcome, reduction of fluoroscopy time, shortening procedure time, and enhancing safety of the procedure itself. And with EP, the most important part is to really identify patients whether they have structural heart disease versus not. If they don't have, then it's assessment of the anatomic structures during mapping procedures. And patients with structural heart disease, we need to make sure we identify cardiac anatomy, if there's any LV thrombus, and identification of arrhythmogenic substrate, right? So that will really take us to where the critical zones are and how we can approach ablation. So now, lastly, I'm gonna tell you about how we do it. And so recommendations for MRI workflow, this is actually one of the task force guidelines that SCMR is putting together. I'm the lead author for this paper. So it really to make sure that we understand the differences between MR conditional and non-conditional, right? So as I said, most of the studies that were done was non-MR conditional. They're pretty safe. And one of the important things that I would mention here is that it really, when you are trying to establish this program, it really you need to make sure you involve every important stakeholder in this particular setting. So the stakeholder, as you can see here, the referring physician, they really play a huge role here because the initial consultation with the patient starts from them. And then it comes to the cardiology, right? So I would combine these two. This will be like the imaging setting, right? So most, I would say, programs are hybrid. They would be run by cardiology reading and radiologists reading. To me, I make no difference because I feel like I've learned EKG and a lot more stuff from them, and they have learned the technical component from me, and I feel like now we basically function like one, right? So there's no really a difference. I love my cardiology colleagues. I actually probably have more cardiology friends than radiology, but that's okay. And then cardiac physiologists, like the EP, it's really plays a crucial role. So you cannot do this, or you cannot run this program without their help. And their help is truly immense, because I would have not been able to show you all of this if I didn't work closely with EP both at NYU and Michigan. I started out in Michigan. We were really scared at the beginning, to be honest, just because we want to make sure we would include patients with abandoned leads. Now there are studies that, that they say that even the abandoned leads are fine. The only thing is you want to make sure you take extra precautions. You speak with the patient. If they feel any burning, then you take them out, right? If they have abandoned leads. So it's really important to have that communication with the patients, and their understanding is really important. And that's why we have here, we need to make sure we have very trained technologists, that it's really the key. And then you also want to make sure you have MRI safety expert. Okay, we have that in both places. So we have one person who basically goes over every single patient, identifies their device, make sure that if they're conditional, then they go through every specific questions that if we scan them, it's going to be safe for them. And also the legal department too, because you want to make sure you have a consent form too, right? We do say it's, all the studies have shown it's safe, but you also want to make sure that you have a consent form. That's another thing that is really, really important. Just so that you can document what you have explained to the patients, their understanding, it's really important. And you explain what the risks could be. And so here is like how we perform cardiac MRI in CID patients. It's basically before scan, we want to make sure we identify any alternative imaging modalities, if there are, for this patient population, that we go through the risk assessments with, every like single risk, high risk scenarios, and then discussion of the risk benefit to make sure, as I pretty much mentioned, to obtain the patient consent. On the day on the scan, we make sure that we have the consent. Then the CID, then the EP here comes in place. We usually have the nurse practitioner who, unless it's unstable VT, and then we have the EP fellow there, and they would interrogate the device and they would turn off the device during the scan. And we also want to make sure that we have ACLS and BLS trained. It's mainly ACLS for all cardiac imagers. We all need to be ACLS trained. And then, of course, that we have tailored protocol based on the clinical question. So that is the key, because you don't want to keep them in the scanner for too long time. And here the key, referring physicians, cardiology, and radiology. So cardiology, EP, very, very important. So the workflow for MR conditional is, I would say, like pretty straightforward, because one of the differences, even though it's all very, very similar, with the only, and actually it's not, for every patient what we do, we would interrogate the EP, interrogate the CID device before and then after. So after will be done immediately after, and then the patients will come like a week later, and then they will have their device checked again, just to make sure that everything runs properly for them. And here is the protocol. So mainly, as I said, if you only need to know whether the patient has an LGE and it's targeted towards ablation procedure, you only need LGE. So what you can do is inject contrast, do the scout, inject contrast, pull the patient out from the table, so they're not in any like RF MRI field. And then when you do the LGE, which is the last part, really will take not more than 15 to 20 minutes, I would say. So the patient will not be in the scanner for a longer time. If for non-EP patients, we would do the entire protocol, and it's really like shortened, the whole protocol at NYU, it's about like 34, 40 minutes, but now we need to go back to 23 because we want to make sure we keep like 30 minutes slot for every patient. But that's a challenge, and maybe that's something that, we can work together between two institutions, how to make sure. I am claustrophobic. I would not like to be in the scanner for an hour, to be honest. And I think that's exactly where cardiac MRI should be leading towards. And so now I'm going to talk about some of the challenges, right? I've told you why we need it. All looks pretty good, but in reality, it's not that easy, right? So here we have this is the same patient, right? And this is the electroanatomic map. So the patient with ICD, when they come in, most of the time we're going to identify artifact. And that is because LGE, it's a GRE sequence, which is the gradient recalled echo, right? And that is susceptible to artifact, which means metal, right? It's inside, and we almost never know what to expect and how to expect. And that's why it's important for either radiologists or cardiologists, and I'll just call them CMR physicians, right? That they need to check, right? So this was done conventional LGE, and this is where we use wideband. So wideband is crucial. And I think we really saw a huge difference in imaging these patients when we would use a wideband, and you see how the artifact, all this bright stuff, it's gone, and we can identify the epicardial fat in the basal anteroseptal wall. So literally, it doesn't work in every patient, and I'll show you that too. It's not that I'm showing you everything that is perfect, right? But what I'm trying to tell you is that wideband has changed the way we practice in this patient population. So if you are trying to establish this program, the addition of wideband is really important. And it's really, really nothing. It's part of the LG. You just click one button, for me at least, right? Not from the technical side, but it's like you click one button, you change, you just make sure that you have it on, and then it really works. So that's exactly what I was pointing it out. This is actually a case that I read, not yesterday, the day before, when I was in clinical service. 35-year-old woman with postpartum cardiomyopathy. She had an ICD, but look where the generator is located. It's really close to her heart. So initially, the technologist called me and he said, so we do GRE. So this is one thing I didn't mention. If we want to make sure that we include cine, we cannot use SSFP. SSFP creates a tons of susceptibility artifact. The only cine image that we can use will be the GRE. So here's the cine, and you can definitely tell that there's a really huge amount of artifact, right? So it obscures the anterior wall of the left ventricle. But then, so what I asked them, and this is something like I have done a lot at Michigan, but at NYU, they're still not doing it, and I'm trying to teach the technologist. When we see, let me just go back, when we see that the generator is here, even if it's here, so not so close to the heart, but a little bit above, then what we try to tell the patients is to raise their arms above their head, and then not by gravity, but that's going to pull the generator up a little bit higher, and it's not going to cause that much of an artifact. But we were not so successful in this patient. She wasn't really able to like raise her hand above the head, and we used the wideband. So this is all with wideband. But however, we still like improved to some degree, but we did see a little bit of LGE in the lateral wall. And she had a cardiac MRI before the ICD was placed, and it was good because we can see that most of the LGE that was seen in the lateral wall was improved. The only residual LGE that we saw was on the anterolateral wall. So this is the study that I did with my medical student who went into dermatology. But anyways, he was really, really good. So what we did here, this is basically the bullseye based on every single segment that we use. And the percentage here represents the artifact volume. Okay, so we basically measure the artifact volume in every single segment in 50 patients, and this was done, this doesn't work. Oh, here. So as you can see here, this was done on LG without wideband, and this is LG with wideband. So see the percentages, complete difference, right? In some patients, they may not go away, but at least in some patients would go. So how can we identify what are the patients that we will have most information from cardiac MRI? So what we did, we tried to stratify by tertiles based on the artifact burden that we're going to see on a conventional LGE without wideband use. And you can see here, if the artifact burden was mild, then you would definitely get a most out of use of wideband. If we encounter moderate artifact burden, then you can definitely see here that some patients will not be able, we may decrease the amount of artifact burden with wideband, but not completely disappearing, which is also good. We can still do in this patient. And then the one that I showed you had basically severe or large artifact burden, where in most of those cases will be very, very difficult to get rid of the entire artifact. And here we may be limited just to a few segments to evaluate, but I still feel that it's going to give you a good information, especially when I speak to referring physicians. They still want to make sure we proceed, and I never stop the scanning. I want to make sure that we can do most what we can and give the most information to our referring physicians. If you are scanning patients with pacemaker, those are the easiest. I almost have never seen any artifact. If you are scanning patients who have a subcutaneous ICDs, those patients are hard. I would probably suggest it's going to be very hard to try. If their generator is on the right side, it's actually a lot better, right? Because it doesn't really interfere with cardiac structures. So this is another example that I want to show you. You can see definitely the patient has a Midwall LGE in the septum. This is all the artifact and was considered as moderate. And using wideband, it was completely gone. So we were able to definitely say or accurately say the extent of Midwall LGE. And as I mentioned, for EP and for targeting ablation sites, it's really important, this patient population. One thing that it's really important to know is the wideband that we are going to use. So I would say different vendors have like different settings. I believe this was done with Philips. This was conventional. You can see that there is almost transmural LGE in the infraseptal wall. This doesn't work, and maybe I've used it too long. Okay, here infraseptal and then inferior wall, conventional LG. This is using wideband with different frequency. So we have 6,000, and why this is important? You want to make sure you use the right one because the wideband frequency is going to affect the nulling. Okay, so you don't want to end up with the nulling that is not appropriate, right? We want to make sure that the myocardium is dark, as you can see it here. So really the best one, it's using 2,000 hertz. So this will be 4,000 hertz here, and this will be 6,000 hertz, and you see how the nulling of the myocardium changes. One of the thing that I wanted to show you, and that's on the next slide, is to look at the frequency shift. So the frequency shift is also really important. Maximum we can go to a frequency shift or offset of 1,000 hertz. And here is the scar right there. If we don't use any, we do see that it's gone. Here it's gone 500. And then the myocardium will be dark. Here the myocardium also be dark. But as you can tell here, using 1,500 or this will be, this should be like more than 1,000, then you basically see that the myocardium is not null, and these images are completely non-diagnostic. So now we circle back to 3 questions that I would ask to cover, which is when we do cardiac MRI in patients with cardiovascular implantable electronic devices, which is essentially to answer the clinical question, why, which is to guide intervention outcomes of patients, make sure we tell patients what their prognosis is based on cardiac MRI, and then how we did it using a practical approach, what is wideband, and how we can basically mitigate most of the artifact burden using wideband's option with LGE. So take-home messages here is that cardiac MRI identifies structural heart disease. Cardiac MR defines CAR, helps to identify arrhythmogenic substrates and guides ablation procedures, and then outcomes are improved if pre-procedural imaging is used for non-ischemic cardiomyopathy. And then when it comes when it comes to non-EP patients, it's really to answer what the etiology is. If the patients have, masses in the heart, we want to make sure we distinguish what is tumor, what is thrombus, and it's pretty safe to do it, to be honest. As I mentioned, I have probably 10, 12 years of experience doing cardiac MRI. Now at NYU, which I'm so blessed, we don't even have to be present by the scanner because it's run by the nurse practitioner from EP. Then we also have nurse practitioner from radiology side. We're only responsible to make sure that we look at the images so we can let the patient go, that we have gotten most of the information, and then we guide the technologist how they need to perform the entire exam and then modify the imaging protocol or tailor the imaging protocol based on the clinical question and the referring physician needs. And with that, I really wanted to thank Frank Bogan. He is the electrophysiologist from Michigan that I really work so closely. EP Michigan Medicine, of course, I spend most of my time there, and New York University EP section. Now I attend all of their early rounds or meetings, and then I discuss every cardiac MRI, and SCMR Science Committee, which we put together all these guidelines for patients with cardiac, who are undergoing cardiac MRI with devices. And I think that's about it, and that's nice view of the East River in New York. Something which I think cardiology is really blessed because all of their offices are right there. Mine is not, but it doesn't matter. Anyway, so thank you, and I'm really looking forward to any questions.
Thank you, Jadranka. It was very, very nice conference, very elegant. We appreciate your input. And actually, this morning, I think Laura Costa is here, and we had to cancel a PEDS patient because he or she had a device. So, very timely conference. Thank you so much. ¿Preguntas?
Well, thank you very much for your great presentation. So I have a question for you.
Yeah.
How did you get wideband?
How do we get the wideband?
Exactly. The changes of the MRI
exactly.
machine to do wideband.
Yes.
Because as far as I remember, is maybe the biggest barrier that we have to start MRI in patients with devices.
And that is a great question. So I have great experience with Philips and Siemens. I used to do GE at the beginning, but now we have GE at Bellevue where we want to start that program too. So at the beginning, when we started out with Philips, we had as a WIP sequence, which is work in progress. And it's something that we collaborated with institutions in United States, and we also developed it. So initially, when I was at Michigan, we developed it first because I think we were one of the first centers that we started doing it along with Johns Hopkins, because they have come out with specific guidelines. At the beginning, we were basically not including patients with abandoned leads, conditional devices, and also patients whose ICD was placed 6 weeks before they requested MRI to be done. But now we have scanned them all. So at the beginning, we developed that sequence as one of our PhD scientists who did it. And then once you upgrade the software, you want to make sure that you can still keep it. Most of the time is lost. So then the second time we got it from University of Chicago for Philips. For Siemens, we got it from UCLA. So they have had the program developed. And then, of course, we had it with Siemens after that as a WIP sequence, which is work in progress. I'm not really quite sure whether now it's a commercially available, but it's something that you can get it, whether it's a WIP sequence or it's commercially now here that we can use it. it's something that always has to come. So we never purchase LGE if it doesn't come with WIP or commercialized for wideband.
Thank you. As far as I remember, in the States, in the past, if you want to move to wideband changes, to include patients, you need those patients need to be inside that research protocol, covered with the high cost insurance, etc. To cover safety things. So still is the same process in the States, because you show that a lot of studies demonstrated that it's safe even in non-conditional devices.
Yes, and that is an amazing question, and I can tell you because I have huge experience with that. Initially, of course, when we develop a sequence, right, it's still under research umbrella. But what we did, and it was very smart to do, because I was leading that program too, so we had a IRB as an umbrella that covers every single research. It was not specific to ICD patients. And why this is not difficult to get is because you don't change anything. It's not a different sequence. You only click a button, right? You want to make sure wideband is there. So it doesn't really pose any damage or any risk to the patients. So as I said, we had a research umbrella, and what we did, when we consent the patients, and that's why I said, it's developing this program, it's a marriage between the stakeholders. So the stakeholders is the referring physician, radiology, it has to be, right? Regarding who is reading it, because the scanners are part of radiology in most places, right? So that'll be one thing. Electrophysiology, right? So they're all combined. And we have a consent form, which also included that we are applying wideband sequence, right? Which is not a separate sequence, right? It's part of the same one, but it's gonna give us a better image quality. So it was not a big deal at all. At NYU, it's even done in a simpler way, because within the consent form, everything is there. We use LG plus wideband. Really, it's nothing extra. It's just to make sure that you speak with a patient and explain them the benefit of a wideband, actually explain them the benefit of cardiac MRI, and wideband is part of it. So it's not something that it's extra research that I would not even consider as a research. It's basically clinical endeavor. So it's part of the consent form. That's why I said the legal department has to be part of that, because you have to have the right wording, and the new guidelines that are gonna come out from SCMR, we do have like specific, not specific, but give like a broad template of how that consent form can look like. Like at Michigan, we had completely different. NYU, it's, I would say, a little bit more liberal to that extent, because they really scan patients all the time, right? Without even any of the cardiac MRI physicians being present, because the volumes are high. So we cannot really monitor every single case. For ICD patients, yes, we have to, because I want to make sure that the image quality is decent, and I'll tell them like some tweaks how they can do things. But yeah, thank you. That's a really great question.
I have another one. If there are more questions.
Yeah.
So as we don't have experience, obviously, in performing MRI in patients with devices. So you mentioned it in your presentation that it's a discussion, make the decision to do that. It's a discussion between the stakeholders.
Yes.
So what are the most common clinical scenarios that you are discussing with your colleagues to decide to perform these studies?
So let me tell you this. When I worked for Frank Bogan, for him, every single patient had to get MRI. There's not really much of a discussion, right? It's ablation procedure. It's really important for those patients. They're going to benefit from it. And of course, I'm here to make sure that I facilitate everything to be done in a right way. The discussion is more with the patient, because here the referring physician really plays a huge role, because they want to make sure that they explain some of the risks they may happen. But as I said, if the patient is stable, most scan is going to run correctly. We have scanned, I would say, a good number of patients with VT storm and unstable VT that they really needed to get an ablation right after. And in that case, we felt a lot better if we would have an EP fellow with us next to me. Even though we're all trained with ACLS, but we wanted to make sure that everyone is here. The key is to make sure you get the patient out, so that the table needs to get out, and then you just turn the device on. So that's basically what we did.
Right, thank you.
Yeah.
Just to comment on the whole IRB and the application that you successfully did in Michigan, we have applied here twice. We've applied here in 2018, and in 2018, we did it through Philips, who's the vendor that we carry here. We have two 1.5s, an Achieva and an Ingenia. And the sequence, despite it's a patch, as Jadranka said, you just have to click a button. It has to come and be approved by the Colombian FDA, because we cannot use a software unless it's applied. So Philips and us applied, it got approved. And when that arrived to the ethics committee, at the time, a physician that worked here, his name is Jose Sinaí Arevalo, said, okay, you can get started, but you, Hector, are going to be responsible if something goes wrong.
Well, nothing is going to go wrong. You just have to be confident. You know,
Right.
all the research, right?
Right.
With like thousands of patients.
But are you gonna visit me in jail if something goes wrong?
There's no way you're not going to go to jail, I promise you.
So now on the second round, so everything got flooded because of COVID and blah, blah, blah. But anyways, the first round in ethics committee got canceled. And now the second round, and I'm not sure if Edgar Salamanca is here, he's the new chair of the ethics committee. He talked to me and he basically said the same thing again. So here in the meeting, we have Philips, we have GE, and we have Siemens, because we were actively looking for a scanner that has commercial wideband available.
Yeah.
We talked last night about the patent. The patent has been released by UCLA, by Ben Ho, and we're basically in the need, and having the world leader of how to do it, and when to do it, and when to do it is going to be very important. But the whole you visiting me in jail is going to go away if these guys here that are present can provide us with the commercial sequence. The RSNA, I was in Chicago. We were in Chicago last week, by basically shopping around on who has wideband available, and that's going to directly impact our next scanner, because our volumes need either one or two scanners. And as I mentioned as of this morning, we had to cancel a 5-year-old that has an ICD, and the reason for it is because we don't have wideband. Here, Luis is the head of EP, Maria Juliana is the head of of heart failure, and I get emails and texts every week of when are we getting these. I've been getting those for the last 6 years, and hopefully with your help, and thank you so much for being a leader in the field, and with the vendors we can have in these institutions and many others. We did a national survey of every single hospital in Cali, in Medellin, in Bucaramanga, in the Caribbean region, and there's 12 people or 12 groups doing serious cardiac MR. None of them have wideband. One has wideband, but it's on and off. But no one in Colombia is using or doing what you did in Michigan and New York, and what basically the world is doing, because of this restriction with the painful.
Right.
But anyways, Luis, you have another. I think William has another question. Sorry.
But just to give you the comment, you're not going to go to jail even if this is still a whip, because it's a white band. It's part of the LGE. That's what you need to tell them, right? There's no difference. I mean, you may go to jail because if something happens to the patients just doing cardiac MRI, right? Which is basically unheard of. But that will be the only reason, not for using wideband. That's part of LGE. That's how I consider it. Okay, questions?
Well, thank you for the talk, excellent talk. So I'm part of the EP team. So I want to ask you two questions. The first one is, I was practicing in a different city here in Colombia, and once in a blue moon, somebody called me because someone took the patient without programming and put to try to do a cardiac MRI, the device. So resetting to the VDI 30 in a dependent guy. So the institution where the cardiac MRI was taken have to pay in money in cash to take the patient and change the device. So that's part of the thing that happened. Wasn't because in Colombia it is not allowed to take the patient everywhere to do a cardiac MRI, especially they have CRTDs, CRTPs. So the other question that I wanna ask you is you have a specific crash protocol, because you say many times that you pull out the patient from the machine, but what happened next?
You just turn on
the leads fail, the device battery is not working.
It's just right. Okay, so no, the reason why the patient was in VT storm, right? So that was the reason why they were not feeling well. They coded we pulled them out, we turned the ICD on, and everything started working well. So it wasn't just because the patient was a high-risk patient.
Well, as you mentioned and you showed, there is the follow-ups of that studies. I have the opportunity to participate as fellow in McGill, Canada, of both of them. So we have to take measures before, during, and after all the parameters. So how do you manage in your workflow there to do the follow-up if the cardiac MRI is taken, if especially the device is not well implanted, that you show the picture, and the device will receive directly all the cardiac MRI. I mean.
Okay, so let me just try to go first to the first question. If I understood correctly, you're trying to tell me that patients who have ICD are not reimbursed by the insurance?
If something happens during the MRI is taken here in this country, you have to deal with this problem, especially if you are the referral doctor.
Is that the insurance?
Is that the insurance?
That is not going to cover because it's scanning patients with ICD.
Well, that's one patient experience that I have in another city.
I see. Well, one of the things, the way we did them at Michigan, and I mean, I don't know if, I can share this experiences. We had patients who were not able to pay for it, exactly to what you said, because cardiac MRI will not be reimbursed if it's done in outpatient setting. So what we were doing, we were cheating the system. We would admit them as an inpatient, and then of course, you're gonna explain that cardiac MRI is needed to guide the procedure, and those patients, basically everything will be covered by the insurance. So we were cheating the system. I don't know if you guys have done that too, but that's exactly what I have helped Michigan to do. So not as an outpatient, but basically as an inpatient to be covered by the insurance. So that was the first question. And what was the second question?
Do you have any crash protocol?
Crash protocol.
Let's say something happened, you are going to do this,
exactly.
and then.
Exactly. So that's why I said the whole protocol consists of this: EP and which will be the EP nurse practitioner or the fellow. And then we have on the radiology side, because at Michigan, most of the studies were done by radiology. We only had one cardiologist with us later in the years before I left. At NYU, it's a different story. We're half and half. We basically read independently cardiology and radiology. So what did we do? The whole protocol entails this. So the patients are evaluated before they come to the scanner, as I have put some of those diagrams. And then the second thing is the device is going to be evaluated before they go to MRI. Then the device is turned off. Then we scan them. Then they come out, and then the device is being rechecked at that particular time. And then they come, I believe, 7 days and then a month later to make sure everything is working correctly. In terms of emergency, of course, that's why we have EP here. We have radiology personnel or cardiology personnel with the crash cart. Everything is here, right? If patients are in code, the first thing what you need to do is take them out from the MR room, right? Because you cannot bring anything inside. So you take the patient out and then you basically act on the spot. But that happened to us only on one patient who was a high risk with VT storm all the time. And we just manage that easily because we just turn on the device, and then the patient was fine. Right after, nothing happened.
I have a question from Cali, from a good friend of ours. His name is Mauricio Mejia. He works at Valle de Lili. He trained at the Brompton, and he's asking if you use 3D LGE acquisition for EP mapping, and what type of post-processing system do you use at NYU?
Oh, that's a good one. So there is a 3D way that, of course, now new Carto systems, right, when you want to integrate LGE into the Carto system, some of the newer softwares will require a very high resolution LGE. However, what was on that protocol, it really takes a very, very low or minimal slice thickness, and that takes a huge time to scan those patients. And then we still have not done the 3D. We're doing the 2D in these patients still at NYU. We may move forward, of course, if the industry is giving us a better sequences, right? Something that is not gonna take us 20 minutes to scan 3D with 2 millimeter slice thickness. That is not gonna work. So we're not currently using it, but we do have the specific protocol that we have to follow it. We're probably gonna go with 4 millimeter slice thickness or 5 millimeter. Currently LG is done with 8 millimeter slice thickness, so we may go down to 4 and 5. Of course, it's gonna increase the scanning time, and we're all about scanning efficiency. I think all of our vendors are on board with that, right? We don't wanna keep patients in the scanner for a long, long time. And in that case, we said, you know, we're gonna sacrifice. We're not gonna give you the functional parameters. We're not gonna give you flow. We're not gonna give you T1 mapping. It's gonna be only LG that we're gonna scan. And when we scan patients only with LG, we wanna make sure that we include every single plane, because sometimes if we see LG present in one particular segment, or there's an artifact, if I do different planes, then I will be able to identify the location, which is really important for LG in this patient population.
Okay, we have one final question. Stephanie, one of our second-year fellows.
Yeah, doctor, thank you for your amazing presentation. My question is, imagine a clinical scenario where you don't have a MRI before implanting a device, and for whatever reason you had it implanted and then you need the MRI.
Yes.
How much time after you have implanted it is it safe to take the image? And if the MRI is from another part of the body, if that changes?
It doesn't. Okay, so the time frame is the same. The safest way to do it is after 6 weeks. If you ask me the question, have I done cardiac MRI in patient who had 2 weeks CID implanted? I would tell you yes. Was it all good? Yes. Was I scared to death if something happens? Yes, I was. But I was there, right? I was there with Frank, and he said, you know, we need to do it. This is the only option. We discussed it with the patient, and we did it, and nothing happened. Most research that is done, it's actually coming from Johns Hopkins in this particular regard, is to make sure we scan patients 6 months after, just to give it the time for the leads to kind of be in a safe position so they would not move. One of the things that we're worried in MR, because it's metal, the lead may move, that's one thing, and number two, it's gonna cause heating, so we don't wanna injure any of the myocardial tissue, right? These are the two, basically more, I would say the most important things why you worry when you're doing this procedure, when you're doing cardiac MR. And that's why the conversation and the trained technologies are important. The conversation with the patient, it's really important. They feel any heating, you just take them out, right? But that has not really, and that's why at the beginning, when we started out, we started step by step, baby steps, right? That make us more comfortable doing this scan. So we started out only doing LGE, really nothing else, because function? You can get from echo. Do you need flows? You can get from echo, right? Why cardiac MRI is really important, as I mentioned, the primary endpoint is the LGE, basically, right? So if that is the only question, then yes, you can do it safely, just making sure that patients are in the scanner between 15 to 20 minutes, only scan LG. That's how we started out. And then we started including function, aortic flow. We basically did every single patient.
Okay, guys, well, thank you so much, Jadranka. Thank you. It's been wonderful, and we learned a lot, and hopefully it's going to give us momentum for moving forward and stop having nasty calls from Maria Juliana and Luis Carlos. They're really, I apologize publicly, we haven't been able to start. I think it's more the limitations that we talk about, but hopefully with the helps of whoever vendor we end up picking, and with your help, of course, we'll be asking you and calling you to New York. We'll move forward. Thank you so much. That was wonderful.
Anytime. Thank you for all being here.
Desde Bayer Radiología, ofrecemos una amplia gama de equipos y medios de contraste para tomografía computarizada, resonancia magnética y hemodinamia. Brindamos servicios de atención personalizada a través de nuestros gerentes de cuenta, un servicio técnico de alta performance, asistencia en aplicaciones clínicas y asesoramiento médico por parte de nuestro equipo de profesionales. También contamos con programas de capacitación continua con líderes de opinión de referencia a nivel mundial. Esto es Bayer Radiología, productos y servicios en una misma solución de portafolio. Conozca todo lo que tenemos para usted en www.radiologia.bayer.com. Ciencia para una vida mejor.